different mechanisms to make sure that when they're at the pharmacy counter, they can pick up our medicines for $25 or less in most cases. But that's difficult when you don't have insurance.
My time has expired. Thank you.
Senator Luján.
Thank you, Mr. Chairman. Mr. Jorgenson, thank you for being here, sir. In your opening statement, you said, quote, patients need both affordability and access. I very much appreciate you saying that. Now, Wegovy and Ozempic are groundbreaking drugs that are making a huge difference in people's lives. The ability to quiet food noise and successfully manage their weight after so many failed attempts is truly a life-changing innovation. But to make a positive difference in people's lives, they have to be able to afford it as well. I've heard from New Mexicans about unaffordability. I'll share a story that I heard from Bernadette. She's a mother of 3 in Albuquerque, New Mexico. In October of 23, Bernadette was prescribed Wegovy for diabetes and a liver condition. Her insurance denied coverage of Wegovy 3 times. Bernadette's Wegovy prescription would have cost about $1,000 after a $300 discount. Her doctor then prescribed Ozempic. After 2 appeals, Bernadette's health insurance company approved her prescription. Even with health insurance, Bernadette's Ozempic prescription would have cost around $1,000 a month. Bernadette made the difficult decision to not pay $12,000 annually for either Wegovy or Ozempic, both prescriptions prescribed by her doctors. She now goes without. According to JAMA, the adult Hispanic population in the United States has a 45.6% obesity incidence. Black and Hispanic people are more predisposed to having type 2 diabetes, a condition related to obesity. The median household income in New Mexico is $62,268, or $5,189 a month. The median household income for Hispanic families across the United States is $65,540, or $5,461 a month. Even with a 40% reduction in the list price, the cost of these drugs represent a huge part of the monthly income of New Mexicans and Hispanic Americans. I also heard through your testimony the coupons or things of that nature that are included from the list price. Why don't you just sell the drug at the coupon price if you're willing to give people a coupon that can afford it instead of that list price that we see on that board?
Thank you, Senator, for bringing up that question and also addressing this, the needs of Hispanic and Black populations. I think that's really, really important. It is not our intention that anyone should pay the list price. The list price is the starting point for our negotiation against the PBMs and insurance companies in bringing coverage of our medicines to patients, and in particular those you mentioned here in having a bigger need. We see that when there is insurance coverage, there is a price point of the $25 I mentioned for 80% of patients. And you can say, what about the remaining 20%? The price point is if $50 or less for 90% of the cases, and then there are remaining 10% where there are either a situation without insurance, or you can say low quality insurance where insurance schemes have high deductibles or certain restrictions on use of the products. And it's important for me to say we don't set the price for those patients. That's a function of the insurance scheme. But for those who fall outside of insurance and actually including the income level you mentioned, we have for Ozempic a support program where we try to help them.
Well, and Mr. Chairman, if I may, Mr. Jorgenson, Bernadette had insurance.
Yeah.
Couldn't afford it.
No.
So I appreciate the statistics and the numbers. She's a real person, mother of 3. There's a problem here. I've not quite understood the notion of list prices with pharmaceutical companies and then the price that they're willing to sell the drug at so they can still make a profit. This sounds like a game to me, and a game that I don't understand, but a game I certainly hope in a bipartisan way that we can get to the bottom of. I very much appreciate Senator Collins' line of questioning at the opening as well. Legislation that's moved out of this committee deserves to be heard on the floor, and I certainly hope we can get there. I'm going to move on. Before I do, while I appreciate very much that the Indian Health Service and the VA include coverage for obesity and for other reasons of this drug, it's still high. It's still a high cost. And when we look at those programs as a whole, I'm still very concerned as to what's happening in that space, but I look forward to visiting with your team more about that into the future. Mr. Jorgenson, because of the work that was done with the Inflation Reduction Act, Medicare can finally negotiate the price that seniors pay for prescription drugs in Medicare. In your written testimony, you have acknowledged that Ozempic may be listed in the negotiations due to its high cost. Despite these contentions that Medicare negotiation will resolve the price, Novo Nordisk has attempted to block the law when Medicare sought to negotiate the prices of insulins. These insulins, by the way, had the list prices of almost $6,000 annually. Now, as we both know, the court rejected that as well. My question for you, Mr. Jorgenson, when you mentioned in your written testimony that you expect Ozempic, your diabetes product, will be included in Medicare's list of drugs for negotiations, yes or no, should Ozempic be selected for negotiation, will you commit to not initiating legal action to stop it?
So, Senator, thank you for bringing up that question. So we share the objective of making products accessible and affordable for patients, no doubt about that. On the IRA negotiation, we have had some concerns that if it's a real negotiation, I support that. But if it's a price setting, I think it will have unintended negative consequences to access to patients for innovation. So it's been described as a negotiation, but it's actually a setting of a maximum price. So I don't know what price we'll end up having for our insulins. I don't know if the PBMs will include it on formulary at all because of that lower price and impact on rebating. So I have nothing against negotiating pricing with the objective of improving affordability for patients. But if it's not a fair negotiation, but actually price setting, I think it will have negative consequences on the innovation being brought to Americans.
Mr. Chairman, as I close, my time has expired. I would remind you, Mr. Jorgenson, of those words that you used in your opening statement again. Patients need both affordability and access. I certainly hope that that rings true, and I would encourage you to sit down with Chairman Sanders and the committee staff associated with that PBM letter to find a place where you will lower those prices and do the right thing and send the message to everyone, because your drugs will save people's lives. 40,000 more people that can't get them today, many in the community that don't get them today, and I certainly hope we can get to that place. Thank you, Mr. Chairman.
Thank you. Senator Cassidy.
I'll defer to Senator Budd.
Thank the ranking member. Thank the chair. Mr. Jorgenson, thank you for being here. According to reports,